Okay, class. So now we'll get into the different types of exercise that you'll utilize in cardiac rehab. So, the general rule of thumb is that there are patients that are at different levels of risk according to the event. So we can prescribe um, exercise fairly, in a fairly wide range of patients who have pretty good stability or higher exercise capacity. The patients who are at a less stable or lower capacity at a high risk, and even at lower intensities, right? So that's kind of reason why we have those cutoffs, or whether a patient someone should enroll in it. Now, when we're prescribing aerobic exercise for patients, we typically want to um, get them to a goal of 8 METs by the time they discharge, and the goal of increasing intensity by about a MET every couple of weeks. And that will coincide typically with our reassessment. So the goal will eventually get people to be able to exercise, again, to a peak capacity of 8 METs or more at the end of 12 weeks. And we follow a progression of increasing intensity by about 1 MET every 2 weeks. So if someone enrolls in our program, at 5 METs, like right after phase one, by the time they discharge, right, if we follow, full 12 weeks and at this schedule of 1 MET every couple of weeks, they should get pretty close to 8 or more by the time they finish. So these are our intensities. Typically, we're going to keep things at a moderate intensity, somewhere between 40 to 80% of heart rate reserve or VO2 max. So duration for aerobic exercise can be the same as apparently healthy individuals, 20 to 60 minutes typically. You may try to get people to accumulate shorter sessions throughout the day, so maybe 3 to 10. But typically for within a session, we're going to keep things between 20 to 60 minutes. Now the type can vary, right? So we can utilize any number of exercises that involve large muscle groups moving continuously and rhythmically. So this could be walking, this could be cycling. Patients love these reciprocal steppers and new step. We could even do elliptical for high-level patients, or maybe even a little bit of the ergometers, a little bit of rowing, depending on how stable they are. This would be great maybe even for some phase 3. But really the biggest thing is patient preference. Like if patients enjoy a certain mode of exercise, or maybe they can work out next to their partner, like that works well. Because again, the name of the game is, one, getting patients in the door, getting them enrolled, and for them to complete a full program to get the most benefit out of a cardiac rehab program. Progression, typically, again, we're going to increase duration before intensity. Patients should be able to achieve 20 to 30 minutes of continuous exercise before we ever increase intensity. And those with low functional capacity or limited symptoms, we should try to gradually work towards 15 to 20 minutes as well as continuous cardio exercise. So if someone can get at least a 20 of moderate continuous aerobic work, then we can start talking about upping the intensity, and that should follow along that same 2-week interval. So again, there's our general rule of thumb for progression for patients in cardiac rehab. And it's really, again, not much different than how we would prescribe or progress someone through a traditional exercise program. It's just, maybe the intensities will be a little bit lower for this as it would be compared to a general population. Now, for resistance training, this was viewed as almost something you would never do in cardiac rehab because there's the concerns on the blood pressure spikes with aerobic resistance training. However, we're finding that there is great benefit for patients in cardiac rehab from doing strength training. It's got to be done safely. So they recommend from the ACSM and ACVPR starting at about 50% of 1 rep max. Some say even 30 to 50%. We want to typically do something that is going to be around a low intensity but a higher load, especially for the upper body, and lower body 50 to 60% of 1 rep max. So keeping it kind of low. Low load, higher duration, more muscle endurance than just pure strength, and a wider group of exercises. So there are some time cutoffs. Typically, we want patients to be enrolled in a minimal period of post 2 weeks after a non-emergent stent, or 4 weeks post an MI or surgery, because they're a little bit more unstable. And cabbage, sometimes that can be even a little bit longer depending on the healing of the sternum, but they might be able to resume lower body exercise a little bit earlier. But the key thing is we want to make sure that heart is stable and not at risk for an acute event before we initiate resistance training for these patients or training under load. But again, if we want to improve strength, if we want to improve function, resistance training is the name of the game. The other cutoff, typically our patients, we want to keep the RPE on a moderate scale. Move my little guy here, and then blood pressure at baseline should be no higher than 160 over 100 to initiate resistance training, either or systolic or diastolic. Interval training, again, we talked about this. Over and over again, appears to be effective and safe for patients with cardiovascular disease. It may also improve adherence because people typically enjoy it a little bit more than continuous work because there's a little bit of a game to it. Like you kind of go up and down, breaks up the monotony of aerobic work a little bit. And it may increase fitness even more so than moderate continuous work in certain populations. We see this in heart failure and other cardiometabolic diseases, diabetes being one, and we actually finding it may have better effects on vascular function than moderate continual aerobic training. So, which is particularly relevant post-heart transplant because we see some unique changes in the coronary arteries after transplantation. And we think that can maybe be attenuated with some of the higher intensity, higher flow that's going to stimulate those endothelium in the arteries. So interval training, again, it's great because it can break up the monotony of training, a little bit more enjoyable. And if patients can't do 20 minutes continuously, we can do these little chunks, little intervals of work, right? So this is, again, the basic format. You do a little bit of a warm-up, 3 minutes on, 3 minutes off, and you repeat that 4, maybe 6 times. So you get the same total duration of exercise, but you get peaks and valleys of higher intensity. And you can even do this with a passive recovery. So you could do, instead of 3 minutes at a lower intensity, you could completely stop and have the patient just recover. So, however it works, best for your patient is fine. Again, just you want patients to be a little bit, stable. And again, this is remembering that it's 60% of their peak. So if their peak is 7 METs, right, we're going to be, maybe at a 4 to 5, right, during exercise. So again, it's matched to the patient. So what we think of high intensity might not actually be, high intensity for us, but it might be high intensity for our patients. And then inspiratory muscle training. Again, we can have patients breathe against these resistance, imposed in these devices to strengthen the respiratory muscles, make them more efficient, so they don't steal as much blood flow during exercise. Remember that metabolic reflex that we see particularly in heart failure at higher intensities. And the great thing about this can be done at home. This can be done as an adjunct to traditional cardiac rehab. This can be used as a bridge to cardiac rehab. And there's even some facilities in Brazil that are looking at doing this concurrently during rehab. So, this is going to be, I think, it's been around for a long time. You're going to learn a lot more about it in our pulmonary unit, but this is a mainstay for heart failure treatment. And again, the great thing is patients can do this sitting down, and it's really great for improving shortness of breath. So patients have issues with dyspnea, right? And getting around, this is a way to treat dyspnea. You'll learn how to test it later on. Inspiratory muscle training, big benefit here. All right, so next we'll move into phase 3. Again, phase 3 cardiac rehab. You might not get coverage, right? The advantage of this is we made those lifestyle changes. We've got patients enrolled in 12 weeks, right? 3 months of exercise. We've done education. We've done a bunch of different counseling, right? And often patients finish these programs, they graduate, and they're like, well, I want to continue. Well, the problem is, maybe they don't have a facility in their space, and maybe they want to be at somewhere they're still a little bit, they're fine, but they'd rather be somewhere close so they can be, near, experts, right? So these phase 3 maintenance programs have existed for that reason. Problem is, it's getting insurance to cover it. And there are other benefits or other things that can be done in phase 3 for maintenance as well, too. So yoga, tai chi, waltz dancing, meditation. These are all things that sometimes get included in phase 2 programs. We call it cardiac potpourri, which is kind of a grab bag or catch-all for things that fall out of the the traditional realms of exercise. But for mindfulness, for stress management, as we talked about, that's a huge component of managing living with a cardiac disease. That practices like yoga and Tai Chi meditation are huge, and especially for something that people can do long term after maybe they have completed their program. So we'll end here in terms of the phases of cardiac rehab, and then we'll get into the referral and participation barriers and process.